RHA.
Okay, thank you for the brilliant operations. Now we move to the Q&A sections. Welcome to the moderators, the Professor Tam, Professor Cheng, and the Professor DIAO.
I think most of the questions have been asked during the procedure.
Hi, okay.
Hi,
I'm
welcome
ready.
back. Brilliant.
Thank you. Thank you.
Most of the questions been asked and answered during the procedure. You did not only a beautiful operation, you were able to
thank you.
answer critical questions.
My pleasure.
The follow-up on my question previously, I asked about the suturing from conventional laparoscopic cortical cyst excision. That you clarified that if it was 3-port, you would suture. You would start the suture at 6 o'clock.
6 o'clock.
And then you would go round to 9 o'clock.
And then
12,
6 to 9 and 6 to 3 separately.
So you would use
conventional.
Again, semicircle and then semicircle again.
Yes, yes. And then
so
anterior.
So one clockwise and then one anti-clockwise to complete the suturing.
Yes, yes. And anterior will also the same to the single incision from 3 to 12 and then to 9. Yes. And make the final nose at 9 o'clock. I mean for the conventional laparoscopy procedure.
There's a comment on the from the floor. Brilliant operation, which I agree is a brilliant operation. And where did the drain exit in the skin? Is it from the umbilical wound or from one of the port side?
Well, one of the ports, the left side, thank you, the left side port from the 3 millimeter walking port.
The left side or the right side of the patient?
The right side of the patient, the left side of the surgeon, sorry.
Okay. And do you routinely leave a drain or in some cases you selectively do so?
For those with severe infection or perforation or the cyst with large dissection plane in the pancreatic segments will reserve a drain, usually for 3 days. And if the drainage volume decreased, continue 3 days, each day less than 30 ml per day, and ultrasonographic showed ultrasonographic study showed no abdominal fluid, and the drainage tube will be removed.
Yeah, this is a single incision operation, so the drain comes off the umbilicus, I gather.
Yes, we actually this advantage of single incision laparoscopic HD. We use the umbilical incision, which we used also for the Rook's loop establishment. We do not need to use other incision, and we do not need any special designed the curved instrument, because the younger infants and the small children, they do not have too much spaces, so the conventional straight instrument can save the space for them. And also the cells can achieve the advanced goal of the minimal invasive surgery. Our comparative study showed the OP time after the learning curve. The OP time is similar between the cells and the conventional laparoscopic group, and post-OP recovery also similar. It can achieve the visual scarlessness, and particularly it's beneficial for the small children because in small children, their abdominal wall is weak. The muscle layer and the facial layer is not very well developed, so it can increase the articulation between the telescope and the instrument. So it also increases the freedom of the movements of the instruments. And the distance between the abdominal wall and surgical field is shorter in the small children. So it's easier for increase the articulation between the telescope and the two instruments compared to the adults is have more beneficial and easier to perform the cells in small children. Thank you.
Yeah, I just repeat what your message. In the tiny babies, triangulation is exaggerated compared to adults. Yeah.
Yes.
There's another question from the floor. With your skills and in your center, when would you proceed for conventional port surgery? From the beginning, I guess it says when do you do 3 ports? I suppose this means when do you do 3 ports operation in your center?
We start conventional laparoscopy HJ since 2001, and after 2011 we used the single incision laparoscopic technique, and we also expand this technique from a simple cortical cyst to each type of complicated cortical cyst, like perforated CDC, redo and stage surgery neonates, and giant CDC. And after the learning curve, I think the results is similar between the single incision and the conventional one.
And now these days, is there any situation where you would do 3 ports instead of a single incision operation?
Actually, nowadays, I think if we can do the laparoscopy, we can do single. we rarely use the conventional one.
Okay. Very good. I don't have further question of Prof Tam. In addition.
Thank you.
No, maybe just to follow up on the conventional versus SILS. As I said, I could understand why you advocate SILS, but remembering that most centers outside of Beijing will be doing maybe 5 cases a year. It's asking a lot for them to firstly to start with SILS, and if we say that the learning curve is 30 cases, then it will take them 6 years to even get to start. So I'm just wondering that so you can showcase your exceptional skills for SILS for a workshop to popularize the technique around the world.
Okay.
Perhaps you should give some consideration as to what the poor guys who will only perform 2 to 5 cases a year should do, and give also advice on that. So that's my suggestion, and I think that's why I ask where you stand, where will you stand. Very basic questions, like where you will stand for your anastomosis, for the conventional laparoscopic 3-port surgery. Some of us might even need a 4th port or 5th port to help us. I mean, it's, I would say that I wouldn't be determined. There's the small number of ports as to the success of invasive surgery. I think we have to be practical. You also mentioned the fact that you do a lot of patients in the newborn period, and the issue of triangulation is less perhaps acute with SILS in newborns. But the corollary of that is that you may wish to suggest that for the inexperienced laparoscopic surgeon, for the older children, perhaps a conventional 3-port surgery wouldn't be a bad idea.
Thank you for your comment.
Okay, with that, I think we should close the Q&A session and move on to the next item on your schedule.
Yes.
Thank you very much.
Thank you. Thank you. Thank you, Professor Tam, Professor Zheng. Thank you for the audience.
Assist